everybody. First of all, I would like to thank our scientific committee and the organizing committee of our department for this successful meeting. I think it's my pleasure to hear with Professor Mark Peters and Professor Hisham Tawfiq. I don't know if he is present with us or not. Okay, now we will move to the next session with updates in management of colorectal cancer with Professor Mark Peters. Okay, Professor Mark, you have the floor with you.
Thank you very much to the nice invitation. If it is possible to see my slides. I don't have my slides for the moment.
Professor Mark, can you please share your screen?
Yeah, try to.
Okay, you will find the green button below.
Yeah. Yes.
Click on it, please.
Yeah, now I can do it. You can see the screen? You have it?
I'm seeing it.
Okay, so I can start.
Yes.
Okay, thank you very much to be virtually in Egypt. So what I want to do in the next 20-25 minutes to give you some update on how to treat patients with metastatic colorectal cancer in 2020. So over the years, the number of therapeutic options that we have for our patients with metastatic colorectal cancer increased dramatically. We still have the chemotherapy backbone with the new drugs that we are combining with each other. In the middle, you have the anti-VEGF drugs with bevacizumab as the standard, but also the small molecule regorafenib that we are using in later line setting. We have the anti-TVR drugs such as panitumumab and cetuximab. And new is the fact that we have seen interesting and treatment-changing data on immune therapy, on pembro, nivo, and ipi. In some cases, especially when we go to the molecular profile of the tumors, sometimes we are using trastuzumab or a combination of encorafenib and binitinib in patients with BRAF mutated tumors. We are also more and more looking for very rare alteration in the genome, for example, NTRK fusions, which are very rare in colorectal cancer. But if the tumor is driven by this fusion, it might be good to treat these patients with inhibitors of NTRK. So having all these options available, it has to fit with our very heterogeneous population. You have patients presenting with synchronous or metachronous disease. The location of the primary tumor, left versus right, is playing a role. Sometimes oligometastatic disease needs another approach than multimetastatic disease. For example, in some patients you can introduce radiotherapy. The location of the metastasis, peritoneal disease, is clearly different from liver and lung metastasis. Like I already mentioned, the molecular profile, and of course the performance status and the possibility that there is comorbidity, which has an impact on the selection of our treatment. We are not so far than in lung cancer, where several mutations are driving your treatment decision, but it's clear that also in colorectal cancer, tumor heterogeneity and also the molecular profiling of our tumors is becoming much more important than, let's say, 5 years ago. And this resulted in this algorithm where you have different levels. You have the performance status of our patients, whether these are fit or unfit to have intensive therapy. Sometimes even we need to offer best supportive care to our patients. The molecular profile, standard we do RAS, BRAF, and with the introduction of immune therapy, also MSI status is becoming much more important, and also HER2 status. In purple, you see the fact that the sideness of the tumor, of the primary tumor, is influencing our decision. And based on that, we make a selection. Surgery, if possible. If not possible, we are choosing for a drug combination, either chemotherapy plus anti-DVAR or anti-VEGF treatment. After 2 to 3 months, we do an evaluation and see what is the response of the treatment. And afterwards, we make a decision to continue or go to a treatment holiday or a maintenance therapy if necessary. This is a 76 years male patient with a medical history of hypertension, performance status 1, with recurrent abdominal complaints since months. At colonoscopy, we found a malignant lesion in the colon ascendens. Pathology showed a moderately differentiated adenocarcinoma, and you see that immediately at that moment, molecular pathology is reported. MSS, RAS, and BRAF wild type. Further staging showed big liver lesion, but also lymph node positivity in the thoracic region. All this information was discussed at the MTD with hepatobiliary surgeons, with the abdominal surgeons, with oncologists, radiologists, and it was clear that this patient was not resectable. Knowing that this patient is 76 with a performance status of 1 and not willing to have intensive therapy, it was clear that we had to choose something else than a triple therapy with 5-FU, a biological, an irinotecan, or oxaliplatin. And that's the reason why we have chosen the Gramont plus panitumumab. And this is the evolution of the disease. You clearly see that we started the combination. After 6 months, we had a nice decrease of the CA level with a partial response on the CT scan. Also, the performance status increased from 1 to 0. We then stopped the chemotherapy and continued with panitumumab in monotherapy for another 4 months with further impact on the disease. Decrease of CEA level, and the patient wanted to go on holidays. We stopped the treatment completely for 3 months, and at that moment we have seen a progression at the CT scan, but also a progression at the CEA level. Performance status went down, and at that moment we reintroduced the same combination, the Gramont plus panitumumab, for another 4 months with initially a good response, but afterwards progressive disease and an increase of the CEA level. At that moment, again, we had a discussion with the patient, what was the next step in the treatment algorithm. So it's clear that today the complexity is not only based on the diagnosis, but also the complete staging at different moments during the disease. You have, first of all, the clinical characteristics with different factors playing a role. You have the molecular status with RAS, BRAF, MSI, and like I said, also HER2 status. You clearly see that imaging is playing a role, especially when you want to go to resection. MRI of the liver is important. Multidisciplinary discussion with good surgeons. And based on that, you have different options depending on in which category the disease and the patient fits best. It's not only about efficacy. especially in certain countries in Europe, we have seen that there is a lot of attention on the 5-FU toxicity, the DPD deficiency, and you have for sure seen these data where, based on genetic alteration, that the toxicity of 5-FU based treatment might have an impact. And in some patients, you have to decrease the dose, and in others, even stop the 5-FU treatment because the chance of toxicity is too high, and even some patients can die due to this genetic alteration. Specifically, looking to some other subgroups, we made some improvement, for example, in the BRAF mutated population. We know that prognostically this is not a good population, especially the tumors bearing a BRAF V600 mutation. We started based on the experience in melanoma with BRAF inhibitors in monotherapy or in combination. And recently we have seen these data of Beacon in second line, where patients which in first line were treated with chemotherapy, then were randomized in 3 different arms: the triplets, the doublets, and the control arm with chemotherapy and an anti-EGFR. What was clear that the triplet targeted therapy was doing better than the control arm, which is shown here. You see the purple curve and here the green curve. Based on further analysis, it's clear that not only the triplet, but also the doublet is doing well. And for example, in Europe, the doublet combination will become the standard treatment in BRAF mutated tumors in second line setting. So clearly there was a medical need. We tried to understand the mechanism of action, and based on that, we made some combination to overcome the resistance of this tumor with a high impact on the prognosis in these patients. But we want to go further, and trying to further subtype these tumors in different categories is mostly based on retrospective data, but it's clear that in the future you will see that all these subtypes have clearly a therapeutic impact. For example, here, the first group where probably immune therapy will become the standard of treatment. This gives me the opportunity to make the bridge to immune therapy in metastatic colorectal cancer. In the US, pembrolizumab is already approved for treatment of patients with unresectable or metastatic MSI or mismatch repair deficient solid tumors. In Europe, it's still not the case. But more and more data are convincing not only the physicians, but also the regulators to use this type of treatment in our patients. There is not only the fact that in these patients you can obtain a good response, but moreover, the duration of the response is relatively long. And it was good to see at recent meetings these data not only on efficacy, but also on quality of life. These data of the phase 3 randomized Keynote 177 study, where patients with in first line with metastatic colorectal cancer, MSI high, deficient mismatch repair tumors with a good performance status were randomized between pembro in monotherapy every 3 weeks versus the standard of care, which was based on investigator's choice. And based on that, we looked for the median PFS, but also the response and the toxicity of this treatment. We see clearly an impact on the PFS, median PFS more than 60 months versus 8 months, with a hazard ratio which was clearly significant. Using this type of therapy in monotherapy even obtained a response of 44%. And if we look to the toxicity, it's quite low, the degree of grade 3 to 5 treatment-related toxicity was clearly in favor of the immune therapy. And at latest ESMO, Thierry André presented the quality of life data, and also the impact of immune therapy was significant in favor of the immune therapy in comparison with the standard of care. So we had the BRAF mutated tumors. We have now the MSI high tumor which have a clear treatment option. What about the HER2? We know these data from the Italian group, which are published, where it clearly was shown that even in later lines, colorectal cancer tumors with their HER2 amplification clearly showed an impact of a treatment with trastuzumab and lapatinib, with a good response and with the stabilization of the disease. Moreover, and going in a less frequent alterations that we see is, for example, how can we target the population, which is a big population, and where we don't have good treatment options. That means, what can we do for the RAS mutated population? You know that there are different types of RAS mutation, and one of these mutations is KRAS G12C. It's around 3% of the population, and we don't have a good treatment option. Recently, we have seen this first-in-class inhibitor, which is a small molecule which binds very specific to the internal part of the receptor. There was a dose-finding study in non-small cell lung cancer and colorectal cancer. And what has been seen that not only in lung cancer, but also these patients with colorectal cancer had a response, and even in some patients, a partial response. On the flip side, the tolerance of this new drug was very good, with a low number of side effects. So this might give you a new options in these patients. For the moment, both in lung cancer and in colorectal cancer, this type of drug is further evaluated, and hopefully the interesting data will confirm in phase 2 and phase 3 studies. Not only this type of mutations, but also, for example, the POL mutation might give you an idea, and this is less frequent. 1 to 2% of the colorectal cancer patients have this type of mutation. Even in this subgroup, there might be a place to treat these patients with immune therapy. We have seen since 2-3 years that NTRK fusion are important in certain tumor type, mostly in very rare tumor type. But if we look today, the experience that we have with larotrectinib and enotrectinib, we clearly see that in a fraction of patients of colorectal cancer, we can find these fusions. And this is shown here. You see in green the patients with colon tumors with these fusions treated with larotrectinib. And even in these patients, which mostly are heavily treated, sometimes we find responses more than 50%. So it's for the moment the question of trying to subgroup these patients with metastatic colorectal cancer, especially when they are becoming resistant to certain tumor types, and think about the rare mutations or the rare fusions that you can find in your population, and to try to find a good treatment option for them. Another idea that is more and more becoming mature is, can we re-challenge patients, for example, with anti-TVAR? It's clear that if you have a patient that is becoming resistant after first-line setting, and then treated with other drugs, that there is a chance that even reintroduction of anti-TVAR might have a benefit. The importance here is to know whether the tumor is still wild type, yes or no. You can do it on tissue, but for example, this is an example where they base their decision on the circulating tumor DNA, and it's clear that the group that had still ROS wild type in the circulation, that it's clear that that group is doing better with the re-challenge than the ones with mutations found in the circulating tumor DNA. So that's the reason why the liquid biopsy is not the future anymore. We are trying to introduce that in daily practice because it gives us more and more information what to do, which type of mutation is occurring, and what is the right treatment option in a given patient. And that's the reason why I think at a certain moment there was the idea to discuss rare tumors. There is even a European organization focusing on rare tumors. But if you hear all this new information, the possibilities that we will treat 1% of the patients with metastatic colorectal cancer with a clear target therapy, it's clear that every cancer is becoming a rare cancer. And that makes it very complex in the future to treat a very frequent tumor as metastatic colorectal cancer. One of the problems that we are facing is still the technology, not only the technology to find the genetic alteration, probably in the future also focusing on proteomics, but also the bioinformatics, and what is especially a problem is the price of this testing. And who's gonna pay for all this information that we want to generate in our patients? Another important issue is we get all this information, and the question is, how important is this for our treatment? Is it clearly a driver, or is it more a passenger mutation that is not playing a role in the progression of the disease? So these are still open questions that we need to resolve in the future to better treatment of our patients. It's even becoming much more complex because we are focusing on genetics, we are focusing on epigenetic alterations, but also the environment and especially the microbiome might become much more important in the treatment algorithm than before. And there might be an interaction between genetic, epigenetics, and microbiomes in the treatment decision that we are making in the future in our patients. So if I want to summarize everything, it's clear that there are some challenges in treatment of metastatic colorectal cancer. For me, every cancer is becoming a rare cancer, and also colorectal cancer. Molecular characteristics change the diagnostic model, but it's more than molecular characteristics. It's the epigenetics, the proteomics, it's also the microbiome. Cancer therapy is individualized, and it's the beginning of the story for colorectal cancer. We have seen dramatic changes in the treatment option for lung cancer, and probably in the future we will see the same for colorectal cancer. If we want to maintain the possibility to treat our patients with the right treatment at the right moment, I think at a certain moment we have to change our model how to treat frequent tumors like colorectal cancer. So probably the model of how we diagnose, how we profile, and how we treat rare cancer, this will be the model for the future for more frequent tumors like colorectal cancer. And by this, I'm more than happy to take questions. Thank you very much.
Thank you, Professor. Thank you, Professor Peters. But because of the time factor, we will move to next session. So thank you for your elegant presentation, Professor Peters.
Absolute pleasure. Thank you very much.
Thank you.
Bye-bye.